Hi, and welcome to our next session. I'm Mary Jo Strobel, APFED's Executive Director. I'd like to introduce our next speaker, Dr. Elizabeth Jensen, who is a pediatric epidemiologist whose research primarily focuses on the etiologic factors in the development of pediatric immune-mediated chronic disease, with a strong focus on eosinophilic gastrointestinal diseases. Dr. Jensen leads an ongoing study that leverages databases and resources in Denmark to study in utero and early life environmental exposures in interaction with genotype in the development of eosinophilic esophagitis. She is also co-leading a new study examining a novel biomarker for understanding the role of early life exposures in the development of EOE. Dr. Jensen joins us today to discuss early life factors and EGIDs. Welcome, Dr. Jensen. Thank you for joining us today to share your work and your insights.
Thank you, Mary Jo. It's wonderful to be here and to have the opportunity to share some of my own research with all of you today on early life factors in eosinophilic gastrointestinal diseases. What I find is when I talk with patients and folks that have been directly affected by EGIDs, a burning question is often, why is this happening? Why is my child affected by this condition? Why is this happening to me? And while I can certainly say we don't know the answer for any one individual, we are seeing that there are some clues that are emerging for our understanding of why eosinophilic gastrointestinal diseases arise. So, as you are probably aware, the descriptive epidemiology of EGIDs is relatively primitive still. Our understanding of why these conditions happen is still in its infancy. So EGIDs themselves our awareness of these conditions only came about probably in the last 20 years or so. And because of that, there's so much that we don't understand still. So I'm going to talk today a little bit about what we do know as far as early life exposures, but it really only touches the tip of the iceberg. And some of our initial clues about factors that may be contributing to why eosinophilic gastrointestinal diseases arise came from this descriptive epidemiology. So descriptive epidemiology refers to incidence, prevalence, helping us understand demographic factors associated with EGIDs. And what we saw was an increasing incidence and prevalence over time for these EGIDs. So understanding this variation in these temporal patterns over time provides these clues into possible etiological causal factors that may be contributing to disease development. Now, it's important to add this caveat that even for these descriptive epidemiology incidence and prevalence, it can be really challenging just to understand that in and of itself. So with increasing incidence, we don't know whether it's true increasing incidence or increased surveillance, although there has been a number of papers now suggesting that it is true increased incidence as well as increased surveillance. And then the denominator, so with any incidence and prevalence estimate, there's some population that we're studying, and depending on what population we're studying, it can contribute to different estimates of incidence and prevalence. And then the last factor is just the definitions of these conditions has changed over time. And for any of the eosinophilic gastrointestinal diseases outside the esophagus, the case definitions for these are not well defined, even today. So this is just showing you that the incidence of EOE, depending on what study. So in that left side there are a variety of different studies that have looked at incidence of EOE, and you can see across the bottom here, and with the 95% confidence interval, the variation in incidence that has been observed. So as high as 18.8, but all the way down to just 0.3 in this other study. So it varies considerably across studies, and that could be because of differences in the population being examined, in the setting, in the study methods, or just time differences. And so this study probably illustrates this even more. So when you look at incidence in Europe, quite low, the number of cases. But if you look at North America, considerably higher. So is that because we're better at finding it? Is it because there's differences, again, in that population? Or are there environmental factors that are contributing? And so all of these can provide clues into what might be causing this increase in incidence. And so this was a study that came out just a couple of years ago where they were looking at incidence trends across time in children in Olmsted County, Minnesota, and saw some evidence of tapering in the incidence of cases. So this is a really intriguing study because, again, it provides some clues into maybe there are environmental factors that are also changing across time that could provide some hint as to what might be causing that increase in incidence. So another clue is looking at the heritability of EOE relative to other conditions. And interestingly, the heritability of EOE is considerably lower than other conditions. So heritability meaning the degree that the disease is present due to genetic factors. And so while we know that there is some family history for many EOE patients, that is certainly not true for a lot of EOE patients. And so there must be some environmental factor that is contributing. So another clue is that this paper is a paper that came out which found stronger disease concordance in dizygotic twins as compared to siblings. And this suggested that not only are environmental factors contributing, but likely shared early life environmental factors. So which early life factors? So a lot of my research is on factors that alter colonization of the gut in early life. And so colonization of the gut happens quite early in life. Actually, we've found now it actually starts happening even a little bit in utero, but most of it is happening in the first 2 years of life. And so some of the factors that have been demonstrated to alter colonization of the gut are things like antibiotic use, how many gestational weeks you were born at, delivery mode, cesarean delivery in particular, potentially mom having group B strep and being treated with antibiotics prophylactically, spending time in the NICU, formula versus breastfeeding, what environment you were in the home or in a childcare environment. Even genotype can actually drive colonization of the gut. And then in early childhood, diet is a strong factor associated with colonization of the gut, and then acid suppressant use. So my research has primarily focused on these early life exposures, and to date, only 6 studies have been conducted. So as I mentioned early on, this field of research is very much still in its infancy. But I'll show you what we're learning, and there are some patterns that are emerging. The data thus far have generally been derived from relatively small sample sizes, And many of these have been what we call retrospective assessments, where we look back at data that was already collected either through the electronic health record, through insurance data, through registry sources of data. Because EGIDs are, relatively uncommon conditions, they're very hard to study prospectively, where we look at some population of people and follow them forward and wait for the condition to arise. So the other important thing to note about most of the studies on early life exposures and EGIDs conducted thus far is that these are in primarily single center studies. So again, small and in a certainly defined population. But these have looked at a variety of exposures, including preterm delivery, NICU admission, breastfeeding, maternal smoking, maternal fever, so indication of mom experiencing some kind of infection during pregnancy, whether or not there were furred pets in the home, and use of acid suppressants, and then, as I mentioned a few moments ago, and importantly, cesarean delivery. So this is a figure summarizing what was known up until recently, and I'll share with you some really hot off the press new data from the study that Mary Jo mentioned early on that I have ongoing in Denmark. But this is summarizing 5 of the studies, and this is showing antibiotic use in infancy has a fairly consistent pattern of being associated with the development of EOE. Cesarean delivery, also fairly consistent, but the estimates that have been obtained from these studies are fairly imprecise still. Smoking, really no evidence of either maternal smoking or exposure to environmental tobacco smoke in infancy. No real compelling evidence of an association. With furred pets, only a couple of studies have looked at this thus far. One study showing no evidence of an association, another one showing a protective effect of having furred pets in the home in infancy. And then a very consistent observation of an association with use of acid suppressants in very early life. So I'm going to drill down a little bit more about a couple of these. So this idea that antibiotic use could be associated with EOE, is there support from the epidemiologic literature? Well, we do see consistent associations between antibiotic use in infancy and development of other atopic conditions. We also see some limited evidence that maternal antibiotic use is associated with other atopic conditions. So these are, other types of allergic conditions, which we know commonly co-occur with EOE. So if we can learn something about what's happening with these other allergic conditions, that might tell us something about EOE. There's also some evidence of an association between maternal infections and development of these other atopic conditions. So if you think about maternal infection, potentially maternal infections would have been treated with an antibiotic. So again, that may indirectly provide some support that there could be an association. The other point worth making is that antibiotic use in children in the United States has been quite common, although it is decreasing with some variation across providers. So if you recall from that figure I showed you a few moments ago, the incidence of EOE does appear to be tapering off. Whether or not this observation is consistent with the idea that there could be an association between antibiotic use and EOE is something that we don't know, but it's certainly interesting that the two do agree with one another. So here is some new evidence that I want to share with you, and this comes from an ongoing study that I'm leading of early life factors, gene-environment interaction, and EOE in Denmark. And this is a case control study where we identified all pediatric EOE cases over roughly a 10-year period in Denmark. They were matched to controls on birth and sex. And we accomplished this by linking health and administrative data sources that are available in Denmark, including pathology, prescription, birth, inpatient, and outpatient registry data. And what I'd like for you to notice here that's I think very interesting is that there appears to be not only an association between infant use of antibiotics and development of EOE, but there appears to be a dose response. So more prescriptions is associated with a stronger risk of developing EOE. And then what's called the defined daily doses, which is just the number of days provided in that prescription. The more defined daily doses, again, the stronger the association. And then also very interesting, when we looked at the age of the first prescription, we observed that the younger the age that the antibiotic was prescribed, again, the stronger the association, perhaps providing some support to this idea that this vulnerable period for colonization of the gut and early life is implicated in the development of EOE when we create what's called dysbiosis of the gut from some of these early life factors. So we also looked at maternal use of antibiotics in this same study, and again, interestingly, found the same dose-response relationship. So maternal use, meaning during pregnancy, use of antibiotics, and the more prescriptions provided and the more daily doses provided, the stronger the association. And again, the closer to the time of delivery, the stronger the association. Again, providing support for this hypothesis that dysbiosis of the gut, in the gut, could be associated with development of EOE. So what about acid suppressants? So you may have noticed that there has been that consistent association. I showed that in the figure a few moments ago. Is this plausible? So PPIs can alter permeability of the esophageal mucosa. And this increased gut permeability can compromise oral tolerance and lead to development of food allergies. And in animal models and human studies, antacid medications have inhibited digestion of dietary proteins and resulted in development of IgE antibodies in response to the dietary proteins. So in animal models and human studies, use of these antacid medications have led to development of food allergies. In observational studies, maternal and infant use of anti-secretory agents, again, acid suppressants, can increase risk of atopic illness in the offspring. So we see evidence in that both the basic science and epidemiologic literature for the idea that acid suppressants could be associated. So acid suppressant in the US is fairly uncommon in full-term infants, but they're commonly prescribed for infants in the NICU and for preterm infants. But as you all know, they're also commonly prescribed in EOE as a first line of treatment for EOE. And in fact, up until recently, use of acid suppressants was required for the definition of EOE or the diagnosis of EOE. So one of the challenges in studying acid suppressant use in relation to EOE is this idea of what's called protopathic bias, the idea that there were early symptoms that led to treatment with an acid suppressant, and what we're actually picking up on is just early treatment of a condition that was already present. But what about use in Denmark, where we have been looking at this question of acid suppressant use and development of EOE? So as with the US, use has also been increasing dramatically in Danish children. And the rate of EOE diagnoses has also increased, and it has outpaced the biopsy rate. So going back to that question, is this surveillance or true increase? And in Denmark, it does appear to be true increase, as we've observed in the US. So here is some new evidence of looking at acid suppressants in relation to EOE from my Denmark study. And you'll notice some very strong associations. According to the number of prescriptions, according to the number of doses. And then we tried to look at whether or not it was a H2RA or a PPI. But it turns out that in Denmark, the PPI is the most frequently used acid suppressant, at least in infants. And here, unlike with antibiotics, we saw a stronger association from 7 to 12 months as opposed to 0 to 6 months. And because of that, it does beg the possibility that this could be driven by protopathic bias. With maternal use, again, we saw this same dose-response relationship according to the number of prescriptions and defined daily doses. Here we saw a little bit more variation in the type of medication being used and stronger associations for the H2RA as opposed to the PPI. And then for timing of last prescription, it was third trimester use that, again, was the most strongly associated. So some of those early life factors, there's a newer paper from Whitmer et al. That looked at preterm birth that observed increased risk in relation to preterm birth. The tricky part with that is disentangling preterm birth from spending time in the NICU. But we also had another study looking at preterm birth and NICU and saw some stronger association with being in the NICU relative to preterm birth, although neither were statistically significant. But this is something that we are currently exploring in the Danish cohort. And we'll hopefully have some additional information to share on that front, possibly next year. So this question of gene-environment interaction is something that I have been focusing on in my research as well. We know that there is some genetic susceptibility with EOE, and there's the thought that given that genetic susceptibility and certain environmental factors, perhaps those two things together is what is increasing risk. So we know lots of kids are born by cesarean delivery, lots of kids get antibiotics, many kids get acid suppressants, but not all kids develop EOE. So there must be something else at play. And that's where there's this idea of perhaps there's something genetic that once you add that environmental factor on top, that we observe development of EOE. So with gene-environment interaction, we have the ability to identify novel susceptibility genes and pathways for pharmacologic targets in disease treatment. We can improve understanding of disease through recognition of disease heterogeneity or differences as described by genetic differences and personalize our treatment based on these differences. And we can identify novel, potentially modifiable risk factors among those that are genetically susceptible. So to date, we've done one gene-environment interaction study looking at these early life factors in relation to genetic susceptibility. So we looked at what's called single nucleotide polymorphisms in the genetic code. And these were ones that had some biologic plausibility of interacting with environmental factors. These are SNPs for short, from genes with demonstrated functionality in gene regulation and association with allergic sensitization. And so what did we find from that? We found that there was some evidence of gene-environment interaction for several of the SNPs examined, but probably the most interesting association that we found was this evidence of interaction between breastfeeding and the calpain 14 SNP. And specifically, among those that had the susceptibility genotype, we observed a 92% decrease in odds in disease in those who were breastfed in infancy. So if you had that susceptibility genotype and you were not breastfed, you were at a much higher increased risk. So just to summarize, incidence and prevalence of EOE has increased dramatically over the past 2 decades. Likely environmental factors are contributing, and we have examined to date numerous factors, but the most consistent and compelling evidence are for these early life factors. But we need to continue to probe for other etiologic clues into the development of EOE, ideally using prospectively collected data, such as what we're doing currently in Denmark, using larger sample sizes. And then also we need to couple what we're learning from the epidemiologic studies with more mechanistic investigations to help us understand what is the underlying biology behind some of the associations that we're observing. Is it this dysbiosis of the gut? Is it epigenetic modifications? There's so much more work to be done. So last, I just want to bring up a way for all of you to help partner in some of these investigations. There is a registry and ongoing patient-powered portal for doing research to answer some of these kinds of questions called EGID Partners. And it's simply egidpartners.org, and I encourage all of you to check it out and join if you're interested and become a part of helping us understand some of these factors that may be contributing to disease development. And I want to thank all of you for your attention and time, and I open it up to questions. Thank you.
Thank you so much, Dr. Jensen. That was truly fascinating, and I think we all learned a lot from your talk. I'm Juliette Ross, and I'm a member of the Board of Directors at APFED, and I'm going to try and pass along some of the questions that were posted during your talk. I wanted to note that the next talk has just begun in the theater. If you're joining us live, you can swap which presentation you are attending. This will also be posted for your review later, shortly after the conclusion. But if you're joining us live and you want to add more questions, please feel free. So you talked a lot about acid suppressants, Dr. Jensen, and we have some questions about that. One is, with the evaluation of acid suppressants and its link to EOE, why is it usually the first route of treatment of EOE?
So it does have anti-inflammatory properties, and it has been demonstrated to be effective for many EOE patients. And so that's why it's been a first-line approach. It doesn't preclude the possibility that acid suppressants could still be a contributing causal factor, but the differentiating factor there is the timing of use of these acid suppressants. So the idea being that in early life, when you're still colonizing the gut, that potentially this PPI could create dysbiosis and lead to these downstream immune dysregulatory effects. Later on, once you've developed EOE, it doesn't preclude the possibility that you would still respond to a PPI, given some of the other effects that a PPI has.
And where do you place a cutoff in terms of early life from a scientific perspective?
So as far as colonization of the gut, that's happening in the first 2 to 3 years of life. So exposure to acid suppressants in that period of time is more likely to have a longer term impact on colonization of the gut. We do know that taking acid suppressants later still does impact the microbiome, but it's probably more likely to be a transient effect.
And does maternal use of acid suppressants during pregnancy have a similar impact?
So it still has the potential to impact the infant by changing her microbiome. So if you think about her taking acid suppressants, it could change the vaginal microbiome, if you will. And so when the baby goes through the vaginal tract, they are likely to be populated with different bacteria than they would have been had she not taken any acid suppressants.
So here's a question. Are you saying that the evidence from the scope used for EOE diagnosis could be from an infant using PPIs during 7 to 12 months instead of true EOE incidents? So I think sort of built into that question is a question about what is a true incidence of EOE.
Yeah, this goes back to that concern around protopathic bias that I talked about. So potentially you would have an infant that is treated with a PPI because they're showing very early symptoms of something that later on gets diagnosed with EOE. So it's not actually causal there. It's just an early indication that they had the disease present, but it hadn't been diagnosed.
And we have a couple of questions about what parents can or should do to reduce these risk factors, such as probiotic use, general advocacy when there are choices available. What can parents do, especially if they know that there's a genetic risk for EOE?
Yeah,
what
so
would
some
be
of these,
protective?
yeah, some of these risk factors are probably unavoidable, right? I mean, there are times when you just simply need antibiotics. That said, I think that there's a movement in the pediatric community among physicians and a whole antibiotic stewardship program to say, hey, I think we need to be administering these antibiotics less than we have been. And there's been some inroads there. But as I mentioned, it's still quite variable. So, in instances where, it's potentially a viral infection, maybe it's not appropriate to have an antibiotic. But I think that, having a good conversation with your doctor about, is this something that we know is an infection? Is this necessary? And of course, if it's necessary, then it's unavoidable. C-sections as well. I mean, we went from, in the 70s, maybe 5% of women having a C-section to, 35, almost 40% today. Again, some of that is not avoidable, but some of it we know probably is. So educating yourself and having those conversations with your provider.
Any thoughts on probiotics?
It's a great question. I would say we don't know enough about that yet. I wish it were as simple as just taking probiotics, but we still don't know specifically, which probiotics and, whether or not taking probiotics actually has any fundamental change long-term on your microbiome in a way that's favorable for your long-term health.
And this might be our last question. I have to just double check, but EOE seems to be more common in males. How do some of the factors that you discussed affect males more than females?
That's a great question. I mean, you wouldn't expect that much of that would be different between males and females. So I guess it would go back to this idea of genetic susceptibility and whether or not there are any sex differences in genetic susceptibility. It's a great question.
Here is one more, I think. Is it possible that when mothers experience a lot of acid-related discomfort during pregnancy that leads them to use acid suppressants, that some of their discomfort is sort of coming from the baby and not only that maternal medication use affects the baby?
Yeah, that's an interesting question. I mean, certainly, pregnancy complications can contribute to that discomfort. How much of that is signaling from the fetus itself? It's a fascinating question.
And we'll make this our last question. Are you saying that the factors you talked about, including antibiotics and acid suppressants, cause EOE or indicate that EOE is already there? Can you just kind of help us tease apart causality, correlation? Thanks.
And that's always where we're trying to get is trying to establish causality. I think that there's very compelling evidence that antibiotics do increase risk for developing EOE. And it may be that in the presence of some genetic susceptibility, it's even more, but that's something that we still need to test. There's also compelling evidence, at least in that initial small study, for the value of breastfeeding in the presence of genetic susceptibility. The PPI question, I think, is the one that I would feel least comfortable saying that we have established some sort of, causal association or causal effect, only because it's really, really hard to disentangle the potential for that protopathic bias. It doesn't mean that it doesn't happen, but I think that more mechanistic studies are probably warranted to really answer that with more confidence.
Thank you so much for clarifying all of those things. I just wanted to add my own 2 cents as a clinical psychologist who specializes in working with parents of kids with various special needs, and as a mom myself of a child with EOE, that I think a lot of our questions are often targeted at trying to understand our own role in terms of blame, whether that's blame for something intentional that we did or something unintentional that maybe was completely out of our control, like whether breastfeeding was possible or C-section was necessary. And I think that it's really important for parents to remember that we always made the best choices we could at the time. So, even if we could go back in time and maybe do something differently now based on the information that you've shared with us today or the other studies that we learn about, we can't change the past, and we didn't do anything wrong at the time based on the information that was available.
Absolutely, and I'm glad you made that point. I mean, the other thing worth mentioning here is many, many, many babies get antibiotics. Many, many babies are born by C-section. Many babies get, PPIs, and the vast majority of them do not develop EOE, right? So there's definitely other factors at play here. It's not any one single factor that's contributing.
Well, we are so fortunate as a community that you are looking at teasing this apart, and that so many of your colleagues are doing amazing research. I hope that everyone who's listening live will shift now to the live presentation in the theater, and that everyone will check out all of the booths on display in the other parts of the conference. And thank you again, Dr. Jensen. It's really been a pleasure.
Thank you. It's been my pleasure.
All right, take care.